Good afternoon, and thank you for the introduction. This afternoon, our topic will be on the challenges in the management of fistula. As you know, ET nurses, the cases that we manage are wound, ostomy, as well as continence. In fistula or enterocutaneous fistula, there is a wound, there's also incontinence, and also we have to manage it similar to a stoma wound. Let me go through some of the topics that I will be discussing this afternoon. The topic cover will be what is enterocutaneous fistula, some of the common causes, and also the management principle, which is very important for the ET nurses as well as the surgical nurses who see these cases very often. Some of the challenges, of course, with the management, how to overcome these challenges will be discussed, followed by clinical cases. A fistula is an abnormal connection or passageway that connects two organs or vessels that do not usually connect. It can develop anywhere between an intestine and the skin. Can be between the vagina and rectum and other places. This is the definition by National Association of Continence. Today, the topic is more focusing on enterocutaneous fistula. So let us see what is enterocutaneous fistula or ECF. It is an abnormal communication between the small or large intestine and the skin that allows the content of the stomach or intestine to leak through an opening into the skin. And there are many different types of enterocutaneous fistula. The categorization can be simple as by the output, categorized by the output. Low output fistula refers to the output that is less than 200 mL per day, and the moderate output fistula involve those fistula that is about 200 to 500 mL per day. And those are called high output fistula are the fistula that excrete more than 500 mL per day. It's quite easy to remember, yeah? Okay, let's look at some of the causes of this very notorious fistula, yeah? About 80% of it are iatrogenic. As you know, these are usually happen during surgery, and about 75 to 85% are post-operative, immediate post-operative. Yeah, these are the patients who undergo operation for perforation. Could be due to various reasons, and it could be also due to the acute intestinal obstruction, which is causing the intestinal wall to be thinned out. The vessels are also stretched so much that it actually cannot accommodate, and it has some opening, yeah. And also intestinal malignancy, whereby some of the patients who are not aware of their condition, only when they have got obstruction, they go into the hospital for surgery, then it is found that they have got malignancy inside, and this type of patient, their bowels are not very healthy as well. And another common condition that can lead to this enterocutaneous fistula is adhesion. So this patient will have severe pain coming into A&E and go through surgery as emergency. When the doctor do the adhesion lysis, the patient's condition is not in the most optimal condition, and the intestines are stuck together. So it is not very easy to separate them, no matter how good the surgeon are. So there is a high risk of having enterocutaneous fistula for this group of patients. Of course, the other one will be the blunt and penetrating abdominal trauma, yeah, post-surgery. Then what about the other 20% of it that is not associated with surgery? They are usually the intestinal anastomotic dehiscence. Dehiscence is wound breakdown, yeah, and anastomotic is the joining part. So the intestine joining part is breaking down, So you can imagine there will be opening, there will be leakage of the bowel contents. Another condition is trauma caused by motor vehicle accident, MVA. And these are also commonly we see, yeah. And the other group of patients are like patients who have got malignancy, patients who have got inflammatory bowel disease, whereby they are going through constant inflammation or infection sometimes. So these patients are quite high risk to get an enterocutaneous fistula, including those systemic disease like Crohn's disease. Other not so common conditions are like the radiation enteritis. These patients are usually, they have gone through some radiotherapy treatment, and because of the damage of the radiation, the intestine have got infection, inflammation, and later it become unhealthy. So the intestinal wall become fistulae. And ischemic, it is not very common. During my work life as a ET nurse, I have only seen one. Okay, now let us look at some of the easier way for you to remember what is the cause of a fistula. It is actually using something that is not very nice. It is friends. They are not friends actually. So F is for foreign body. R is for radiation. I is for inflammation or infection. E is epithelialization of the visual tract. This one was not covered earlier because sometimes the patient have got some tubing that is connecting to drain out certain things, but when the drainage is less, the tube is removed. But there is some epithelialization in the fistula that form tract, and this tract can be a fistula. Then neoplasm is malignancy. D is for distal obstruction. If distal part have got obstruction, the intestine will be over distended. The intestine will be thinned out and is higher risk for getting a fistula. So this is something that we can remember easier, yeah? Okay, what are the symptoms? The symptoms include post-op abdominal pain. This is also quite often happen when the patient is still in the hospital. Post-op abdominal pain, tenderness, sometimes distension, and more obvious one will be the enteric contents that is coming out through the wound. So when you see some greenish stuff coming out, you know this is already quite confirmed. It is fistula, enterocutaneous fistula, and the patient may have got high fever, can have diffuse peritonitis because of the infection. Can imagine the bowel content is flowing into the peritoneum. Okay, sometimes when the patient is having the fistula, it also causes them to have a lot of other complications that make the management very challenging and complex. One of it very commonly seen is the skin excoriation. I'm sure you have seen quite often. They have got skin redness, sometimes they have got abscess or sometimes sepsis. Yeah, fluid electrolyte imbalance is also a common occurrence because of the output that is coming out a lot. If it's not managed well, the output is not measured correctly, all this can happen. We normally will emphasize on managing the fluid and electrolyte imbalance for fistula patient. If it's some sepsis or some infection inside, the patient can have paralytic ileus. Yeah. Then another more challenging complication is malnutrition. Sometimes the patient cannot eat orally. They can only depend on some TPN and other nutrition, parenteral. So this is not really that optimal for the wound to heal. Now, even though sometimes the patient already have got the bowel content that is coming out through the wound, but that is not the definitive diagnosis. Usually the doctor will go through some definitive investigation, example like ultrasound, CT scan, fistulogram or barium is a small bowel follow through. Of course, endoscopy can be one of the diagnostic method as well. Now, coming to the management, in general, this is medical and surgical management, as well as other disciplinary that has to come together as a team to help the patient. If the patient come in very acute stage, they need stabilization, the fluid replacement, the measurement, the intake output, all those are very important, and the IV fluid, how much to give, how much to replace, yeah. Besides that, the doctor will be also trying to find out where is the source of sepsis, whether there's any sepsis inside. Besides that, to manage the output, because sometimes too much of output, the fistula will cause problem, like we mentioned earlier, the fluid electrolyte imbalance, the skin problem, and also the wound may not heal. So the output management includes giving growth hormone like somatostatin, octreotide to reduce the output. Sometimes the doctors can also use H2 blocker, which is directly reducing the gastric output to reduce the bowel content. That may help in some cases. So coming to the nurse's role, we have to be very, very careful or skillful in doing the peristomal skin care for the patient. Yeah, we will discuss further later. And of course, that is not forgetting the role of the pharmacist that will prepare the parenteral nutrition for the patient if the patient is prolonged. Yeah, when the patient can take orally, then the dietitian or the nutritionist will come in to make sure that the patient is able to take some oral intake, because sometimes some doctors are very worried about the oral intake, but it is helpful in some ways. Yeah, normally they have to observe and see if after oral intake it is not having more output and things like that, they will continue, and it is more helpful than just depending on the parenteral nutrition. Finally, if the wound does not heal spontaneously, surgery is the next definitive treatment for them. Now, treatment, we can see from most literature, it says about 90% of the fistula will heal, enterocutaneous fistula will heal within 5 to 6 weeks. And they also pointed out that low output fistula more likely to heal. However, the fistula that have got long fistula tract length rather than those wider opening fistula, they have got higher chance to close. Yeah, because of the approximation and also the output. Yeah, and patient usually will need surgery eventually if the wound did not heal. Medical treatment, as I mentioned earlier, to reduce the gastrointestinal output. Okay, now let us look at how some of these enterocutaneous does not heal and why don't they heal. Yeah, generally those enterocutaneous fistula that is with spontaneous, that happens spontaneously, will not likely to heal, because to start off, the intestinal health is already not so good. Blood supply may be poor, and nutritionally wise, they are not that optimal. Coming to other condition, it is like fistula that is more than 6 weeks. As you know, if it doesn't heal 6 weeks, then the patient may have to go through surgery. High output fistula is one of the reasons that is not likely to heal, may heal, but it is not likely. And also patient that is having the sepsis inside, it will take long time and maybe it doesn't heal. Of course, the patient that is not taking orally and no TPN, they are poor nutrition, the wound will never heal. You know the principle of wound healing. We need good nutrition, yeah, to support. And for other types of slow healing fistula will be presence of distal intestinal obstruction, which I mentioned earlier, and patients who have been taking steroid or aging patient, it is also the factors that is contributing to slow healing or non-healing. Managing fistula, it is very challenging, even for ET nurses who have been managing quite often, but it still remains as one of the most difficult type of wound to manage. The challenges include the effluent containment, the skin integrity, not easy to maintain that. Wound healing, it is forever, the wound will be there until there's something that you did right, then you can see the wound that will start healing. That is not only the role of the nurse or the doctor. Patient also very important. If they are malnutrition, then it will also not contribute to the wound healing. Yeah. The other challenges is managing the patient who have got a fistula is the content is malodorous, making this patient very low self-esteem, depressed, very poor body image, and some of them they don't even have the motivation to get well. Okay, now we just touch briefly about the principle of fistula management before we go on to other parts of managing. Yeah. So this is something that is quite simple for us to remember is in the acronym SNAP. SNAP, S refer to stabilization, that is in the acute stage. The sepsis control, also acute stage, and skincare is all the time from beginning until the end. Nutrition will be also should be all the time as well, and it also involves the pharmacist, nutritionist, and the patient family as well. Anatomy, A is you must evaluate where the fistula come. The doctor will also check where is it come from, whether it's a proximal, whether it's a distal, whether it is high output, low output, and how to manage that. So all these are very important assessment. Then P refers to the plan to deal with the fistula. If for the team management team, maybe doctor think this one will need some output management, then they will do whatever that their part is. Nutrition is one of the important area they will not neglect. And of course, as a nurse, what you want to do with the pouching system or other method to manage a fistula, it is very important as well. Now, come to the first one, that is containment of fistula effluent. Very important, we have to have very accurate measurement of the output and the replacement, especially in the initial stage. Yeah, with pouching, it is able to help the patient to have a more accurate containment of the output. It is also able to help us to manage the fluid and electrolyte balance, because sometimes the output is the first thing that you notice how much you need to replace and all that. Not until when you see the blood result. Blood result maybe one day after that, but of course, if it has to come in as well to check and see what electrolytes is efficient. Yeah. Using pouching system for a fistula patient, it will be very good. That encourage them to do ambulation. Imagine if the patient having thick gummy balls and the dressing is not very secure, anytime the dressing can fall off. So this will not encourage the patient to ambulate. Whereas with a pouching system that is more secure and not smelly, the patient will be able to ambulate and move around easily. And lastly, the pouching system has to be not confined only to the nurses in the hospital. It has to be pass down or teach the family member or patient to manage themselves, because fistula will take a long time to heal. Now, the second challenges is skin integrity. It is not easy to manage the skin integrity, especially those output is very high. Yeah, pouching system usually is only required if the output it is more than 50 mils per day. It is still considered a low output fistula. Yeah, up to 200 mils. And then if the patient having uneven abdominal plane like this patient here, they will have a lot of challenges in managing them. Fistula opening below the skin level is another difficult part. How do you want to fit in the pouching system very snugly so that it doesn't leak all over? And depends on the proximal or distal fistula. Proximal fistula, the output is more corrosive, so it's more important to manage the skin health. Yeah, and of course the excoriated skin will be a problem for you to do the pouching system because of the poor adherence. Now let's go to the other part. Yeah, the wound healing. For most of these fistula patients, they also come with a wound. Usually it's the wound breakdown from the surgical wound. Wound dressing become very important for them to heal. If the wound it is a high output fistula, dressing may not able to stay in the wound. So usually pouching is the immediate management until the wound is less output, then only we do dressing material. For those fistula that is low output, we still can do some form of dressing, absorbent dressing. Example like hydrofiber, your foam dressing, or even sometimes the seaweed dressing. Yeah, you can use any absorbent dressing, and the skin protection is very important. In some cases, the doctor will opt for vacuum assisted closure, VAC. This is one of the good way to manage the output as well as healing the wound. In some centers, it is not very encouraged because there are also some literature or some clinical study showing that VAC is one of the reason that the patient will develop second fistula because of the suction. So this one have to be very careful when handling. But it does help in heal the wound much faster. Okay, now for challenges for nurses to manage a patient with fistula, it is managing their emotional part. Body image is something that at times we also overlook. Yeah, because the patient with fistula, it is malodorous. There is a wound there. Sometimes they lost weight. They are emaciated. They also have got bad scarring after that. These patients, they may not have the motivation to eat well. They may not want to mix around. All this making the management more difficult. Then the other area that we are looking at is when we know these are the challenges, now we will need to know how to manage these challenges. Yeah, one of it is we mentioned about skin and integrity earlier. So protecting peri-wound skin is very important in managing fistula wound. So when you have a fistula wound, skin barrier is very important so that you can protect the surrounding skin so that it doesn't break down further. If the skin already broken down, you can protect it so that it help to heal the wound. With stomachicid powder, you can apply onto the open wound area to protect the surrounding skin so that it help to absorb the excess moisture. It also help to heal up the wound and allow the skin to form back. And after using the powder, because sometimes these wounds are quite big, the powder we may use a little bit more. So it's very important to use some skin barrier spray that is to protect the surrounding skin. Using the powder has to be adequate and not too much. Yeah. Finally, it will be the good pouching system that will help in the in managing. Yeah. If the pouching is no good, there will be still some leakage and the wound will not heal. Now, if it's sometimes the fistula have got multiple opening, so you need to identify where the drainage outlet. Sometimes you may have got 3-4 opening, but not all the opening have got output. So if you have access already, you know this is not excreting anything. The two smaller one also not excreting anything. And also sometimes you look at the ostomy. Sometimes the ostomy will be totally nothing come out, everything come out from the fistula side, then a bit more difficult to manage. If the output come mainly from the ostomy side, it is still easier. So in this case, those are not excreting one. You can do dressing, you can cover protect the surrounding skin. You only need to pouch the bottom fistula whereby the output is coming out. Now, assessing the skin, peristomal skin, after you have done the pouching is something that you have to regularly check. Yeah, if it's excoriated or inflamed or fragile, you need to do something about it. If it's excoriated, you need to protect the skin by using some stomizing powder, the spray, skin barrier spray, as well as the hydrocolloid that can protect the surrounding skin. Inflammation, once the inflammation is subside, then it will be easier to manage. Otherwise, it will be very fragile. And on uneven surfaces, you need to fill up the unevenness over the side. Yeah. And of course, I think when we assess the patient's fistula, we also assess the abdominal plane, because when you want to do a pouching system, you want to make sure that the pouching system stay on. If the patient have got a lot of skin fold and you are not aware of it, when the patient lying down, you may not see it. You just apply the bag. When the patient sit up, that is where the fold is, and the leaking will come through the skin fold area. So best way is to sit up the patient and you observe first where the folds are, and you need to fill up those areas so that when you apply the pouching, it will be more secure. One of the important sign of one of the complication is infection for fistula patient. So very carefully we have to do aseptic technique, although sometimes inside there, you know, it is already quite high level of microorganism, but we do not want to introduce anything from outside to the patient. Vital signs is important to see whether there's any infection, sepsis and all that. Or sometimes patients suddenly have got severe abdominal pain. This is something that you need to inform the doctor or tenderness. Yeah. Okay, now coming to, you know, how to manage some of the difficult area. Now let us look at how to select the correct pouching system. In fact, we can use either one-piece system or two-piece system. Both have got its advantages and disadvantages. One-piece system is easy to apply, but they can only drain from bottom. Two-piece system allows the nurse to open up the pouch and clean the wound, clip it back. It has got both functions. It can help to drain as well as allow the nurse to do the dressing. And of course, the selection have to use appropriate size, not too big and not too small, then it will leak. If you see the skin is compromised, skin protection, yeah, even before it become compromised, you have to do some skin protection for the patient. And accessory is something that you need to know what is for what. Yeah. Sometimes the wound is so big that you don't have any bag that is big enough to accommodate the wound. ET nurses will do some innovative ways to extend the opening of the pouching. Yeah, you can see this is combining two one-piece system joined together, and then you can open up for a bigger area. In this wound, maybe on top here, if there's no output comes out, you can do dressing, seal up this area, and just concentrate on the below opening. Yeah, just pouch the below. Now I will share with you some of the cases that I managed. This is case number 1, Mr. W, 46 years old. He's colorectal cancer stage 4 patient. Anterior resection done with temporary stoma. He has been managing his temporary stoma until closure. After closure, then he has got abdominal pain, so admitted, most likely is adhesion. So re-laparotomy done. After that, the patient have fistula form at the main wound. So suddenly the output comes out, even though it is the similar management like a stoma. He said he doesn't know how to manage, and he was very depressed. And because the wound is quite long, so he chose to use the 100 mm two-piece system pouching, which is also not very comfortable for him. Somehow it still leaked. So when I went in to see him, I observed and see where the opening, where is the high output area. Notice that on top it is low output. So I decided to use some dressing for the top, and the below fistula I use some one-piece system to manage. Before that, I have to level up the skin area with paste. Yeah, we can also use some seal for this area to make sure that it stays on. And case number 2, Madam A is 67 years, Tepsodan, developed multiple fistulae. She has got very active peristaltic movement. She was using 70 mm skin barrier on a fistula that is 100 mm diameter. Somehow she doesn't like the 100 mm because it was like not so comfortable. No choice, I have to protect the surrounding skin. Luckily, the fistula that is over here, it is a bit more protruding, so I can cover this part. And even though the 70 mm only can accommodate to until this area, but it was good. It doesn't leak. Lasted about 5 days, so the appliance change every 5 days. And the skin exploration have obviously reduced. Case number 3, this boy is 7 years, laparotomy with burst abdomen, high output fistula, wound size that was 15 by 25. Yeah, quite big, painful. And the goal that time was to prevent infection, protect the skin, and also to heal the wound. So measuring output accurately and provide comfort is very important for the little boy. Yeah, luckily that time I have got this appliance that is called Wound Manager, can accommodate up to about 30 to about 30 cm, I think. So we apply this, and the nurses can drain from here, and they can also even drain to a urine bag. At the same time, there's a window here they can open up and do the dressing daily. The wound actually heal up quite fast, and you can see from here, this is July 10, 2001, and this is 26 July 2001. So within about 16 days, the wound has improved. But unfortunately, after that, I don't have any more samples of the wound manager. We have to modify something to protect the skin, and need to use the gumji, changing gumji frequently, maybe every 4 hours. Eventually, the skin improve and heal. Case number 4, Madam A, 45 years, ileostomy done, multiple fistulae, and skin exploration. manage with, that time we do not, this is one of the very old case as well. That time we do not have more sophisticated items. So I managed with stoma adhesive flexible wafer and one-piece system because there are a few opening. And stoma adhesive powder and paste for the patient. Eventually, you can see the wound improve. Okay, talking about the management of some of these challenges, it is not only for the nurses, it is also we also guide the family member or patient to do on their own, because the wound will follow the patient for quite some time when they go home. So they need to continue the dressing at home, do accurate measurement nutritionally. They have to force themselves to follow some of the nutritional guidelines. Yeah, they need to build up the body tissue to heal. Medication and ambulation, emotional support finally. All this will be very important in the healing of cutaneous fistula, because it needs a multidisciplinary approach, utilizing the knowledge and skill of not only the surgeons, but also wound and ostomy nurses, especially specialized nutritional support team and the caregiver. With that, I conclude my talk. Thank you for your attention.